As many of you, I used to move my head back when I see this type of videos, but worse than the videos are the complications. In the 80s or 90s, the procedures used to be definitively less natural than those of today, but at that time, the knowledge was limited. In the last 15 years, we have done a qualitative leap in survival, coverage, naturalness, and donor management. If you want to do hair transplantation, there is no reason to study, research, and do the right learning curve to improve your knowledge and outcomes. If you are here, it's because you want to learn. Don't confuse your targets. Alopecia can lead patients in hand-up, depression and insecurity, but bad procedures can destroy their lives. And the depletion of the donor area is one of the most terrible complications because of the limitation or decrease of any possibility of surgical repair. The popularity of FUE has greatly increased over the past decade. What was once considered an acceptable procedure for only a limited number of cases has now become the standard for severe and advanced alopecia cases. As the attractiveness of FUE solution intensified, so did the expectation of the patient, forcing surgeons to address the need for increased graft number in a limited surgical time frame. Thanks to enhanced technology and techniques, superior instrumentation as well as the highest skill of doctors and technicians, giga-sessions of 4,000 grafts or more in one session became possible. However, giga-sessions are not without risk and are certainly not applicable to all cases. With giga-sessions came a new problem, overharvesting and donor depletion. As we saw, the use of the micromotor allows the quick puncture of all the donor area. They usually do a large number of deep incisions with a wide punch, without loops, 1000 to 2000 attempts, and then pull quick, steadily and indiscriminately the graft from the donor. They can probably harvest 4000 units in less than 3 or 4 hours. With easy patients, they can probably obtain relatively good graft, but in moderate or difficult cases, the level of transaction and trauma are important, more as less experience of the technicians involved in the procedure. So, extraction becomes a lottery. You can have good graft or not for your recipient area, but the residual non-aesthetic result in the donor will be the same. Also, because of the limitation of time, the area of extraction is usually limited to the AC1, occipital and parietal, in an inconsistent way, leaving visible changes of density, even with a normal hairstyle. That limitation of time during placement also entails that if they have bleeding, the use of anesthesia with adrenaline without medical control will be increased, with the risk of skin necrosis. There is no mystery. Depletion becomes due to an uncontrolled extraction of the donor without a minimum anatomical knowledge, or having this knowledge without taking care of the health and expectation of the patient, focus only in the business. They play with a long time that a HT needs to grow, and when the patient asks about his donor, the answer is always the same: don't worry, it will improve with time. But no. The reaction of the patients is always the same. They want to be as before. A great percentage don't care about the recipient and only want to fix the donor to be again a normal bald person. But how can we arrange this? Difficult, very difficult. Each case must be assessed in a very particular way, depending on the degree of depletion and the remaining donor area. In some cases we can use BHT from the beard to improve the donor. Actually, these are recent complications, so we don't have many cases resolved. In addition, they have tiny residual donor areas, so the number of grafts per procedure can be harvested are small, reason why it lengthens the time to be repaired. Let's see some cases. This patient has had 3 surgeries and a total of 6,000 grafts extracted, with poor survival in the recipient and a catastrophic result in the donor. The objective was to repair the depopulated areas of the donor and fill the lower part of the crown. 3 small surgeries were performed with 12, 13 and 1200 grafts, combining 50% of BHT from beard and some scalp extraction in the few areas that had not been touched in the previous procedure. We don't have the final result, but in the comparison after 2 procedures we can see a homogenization of the donor coverage and a more normal image of a person with a usual alopecia pattern. The 2 patients below are twin brothers, who underwent 2 procedures for a total of 5500 grafts, the same bad result in both. The first one usually wears long hair. 2400 grafts were extracted in the first procedure, of which 600 were from BHT, for the frontal and mid areas. We wait 1 year for his second procedure with 2300 grafts, 700 from beard, and a third procedure 1 year after with 1400 grafts, 800 from VHT to finish the crown and increase the general density. The video showed the result before the third surgery, and remember that 30% of this hair is from veía. When the donor and veía texture are similar, the aesthetic result may be adequate, but we must mix both types of hairs in the recipient area. His brother usually wears shaved hair, the same background with 2 surgeries and 5500 grafts, without result in the recipient and the consequences for the donor that you can see in the photos. Same strategy as his brother, with a first 2100 graft procedure, 600 from veía for the frontal area, a second a year later with 2300 grafts, 800 from VHT for the crown, and the third one with 1400 grafts, 800 from veía to finish the crown and strengthen general coverage. He has a similar result with a moderate coverage but a clear naturalness improvement. If you pay attention, you will see pigment in both scalps due to several bad SMP procedures. The following case is from a patient on long-term treatment with finasteride who has gone through 3 strip surgeries and 2 FUE procedures with poor outcome in his recipient and the disaster you can see in the donor. We performed the surgery to repair the frontal third and scar, extracting 2100 grafts, 500 from veía, with a very positive result, and a second procedure 10 months after with 2200 grafts, 700 from VHT, now waiting for result. This patient has only 1 FUE surgery, but enough to destroy his donor area. We have done 4 surgeries in 6 years with 21, 15, 13 and 700 to repair his recipient area. Small surgeries having the time to recover the donor has been the strategy in this case. We can see a close view of that donor before the last touch-up. The light color of his hair helps to camouflage the lack of coverage. Next, a case with multiple surgeries and an acceptable result on the recipient, but donor overharvesting. We did 2 procedures, 900 and 800 grafts, combining scalp and VHT to increase donor coverage. Final photos show the result after his first surgery. When the overharvesting is in an advanced alopecia, the possibilities to offer a moderate coverage are lower, and we must plan several small surgeries knowing that we are in the limit. But sometimes, with the white hair, we can pass over that limit with a very positive outcome for his first surgery. But not all cases are so awful. Sometimes are local depletion located on the easy areas, occipital and parietal. In this case, to homogenize the donor, we must extract as negative of the previous surgery. In this patient, extracting only 1600 grafts, we homogenize the donor and augment the coverage of his recipient. This case is similar to the former, but because the extraction was performed by 2 different technicians on both sides, the right donor area is worse than the left. Making a good extraction strategy in the untouched areas, we homogenize the donor, repairing both donor and recipient. 2200 grafts in a low-cost clinic partially deplete this patient donor area. Local extraction always exposes the different densities. The strategy again to homogenize the area, extracting only from the virgin areas. 2 procedures of 19 and 2400 grafts gave the patient a normal appearance. A similar case with the same poor result, with a local severe extraction in the occipital area. In this case, the patient wanted to repair the donor more than the recipient, so we extracted 300 veía hairs to place in the area and 2900 for the recipient. The video shows his early regrowth at 5 months with a nice homogenization of the donor area. Lastly, I want to bring a case with 5 strip and 2 FUE procedures with a very bad result and firewalls due to the progress of the alopecia that worsens his situation. Luckily, the patient has a very good and full beard with similar characteristics to his scalp hair, so we could repair with 6000 grafts in 2 procedures, 40% from beard. Finally, the best weapon that we have to fight against depletion or any other complication is the education of the patient and prevention about bad practice through the same channel those teams use, internet and forum. I'm conscious and convinced that the way to avoid intrusion in our profession is not going against doctor or nurse. Pedagogy of the patient showing complications that bad results can lead to with the wrong surgeon is the best way. Information, information and more information. And thank you very much.